Sure.
Lovely. Thank
Lovely.
you. Thank you. I thought she only referred to you as lovely, Phil.
I don't know. You're growing on me, Mansky.
Thanks, Ash. Thanks, sponsors. We have a great session tonight. We got two great guests. Let me introduce our normals. Phil, tell everyone who you are real quick before we get to our special guests.
Hey everybody, Phil Page, Baton Rouge, Louisiana, Franciscan University, DPT. Glad to be here. Thanks to our sponsors, Ashley, for pulling this all together.
Barb Hoogenboom.
Hi, I'm Barb Hoogenboom. I'm the editor-in-chief of IJSPT. I hail from Grand Rapids, Michigan, and Grand Valley State University. And I'd like to thank Ross and Dr. Dillingham for being here tonight to lead the Journal Club with us.
Awesome. Ross, can you I could read off your guys' stuff is like so long. We would the discussion, I think half of our hour just talking about what you guys have done and what you do. Do you mind introducing yourself just really quickly and then introducing Dr. Dillingham since you know him better than any of us?
Absolutely. Yes. Thank you for asking us to do this. And it's my honor. I'm a physical therapist out in California in the Bay Area in private practice, but have a lot of affiliations with a whole mess of different sports teams, colleges, professional organizations and things like that. Been very, very fortunate to be practicing for the better part of 25 plus years as an athletic trainer as well prior to that. And that's actually how I met Dr. Dillingham. I was a graduate assistant athletic trainer at Stanford when Dr. Dillingham was our team physician there, and just had tremendous guidance from him, from being able to talk to him on a weekly training room meeting with all the athletes lined up. And I would hand him my little list of all the updates of all the people he'd be seeing. And he'd just look at me and go, "Thank you. I appreciate that." And then go in, bust out all these athletes and come back out and go, "Okay, this is our plan." And so ever since then, it was kind of that great camaraderie type of relationship, and really helped mold my career going in from athletic training to physical therapy. So I'm honored to be able to have Dr. Dillingham here. So I'll let Dr. Dillingham take it from there.
Thanks. Dr. Dillingham, can you just tell us briefly about yourself?
Okay. Well, a couple of things. Number one, I boarded in orthopedics and physical medicine. And my fellowship, although we're talking about sports tonight, was in spinal cord injury.
Oh,
and what really happened to me is I went to Stanford to be an academic in spinal cord injury, and nobody cared about it. And I said, okay, I got to do something up here or they're going to fire me. So I opened a sports clinic. But the real part of that that's important is that throughout my career, what I learned in physical medicine has shaped me. I go into the lab, I go into the gym, I do the transfers, I put on the braces. I mean, I really became a huge proponent of physical therapy. And so I consider myself a PM&R guy who can operate more than an orthopedic surgeon is a primary designation, which means a lot of focus on diagnosis, technical exercise of surgery. Yeah, that's important. But then what do you do on the back end? Most guys can do an operation reasonably well. How do you rehab it? Who do you use for rehab? Can you tell good rehab from bad? How do you handle a complication? I've told my fellows many times, if you write a prescription, evaluate and treat, you're in trouble with me. Give a diagnosis, give information, work with the therapist, and work with therapists that act as professionals that can analyze things that aren't just on a cookbook type of thing. So I've always made a point of knowing the people I work with, like Ross, being able to tell people when I refer them, I want you to see this person. I'm not sending you to the clinic. I'm sending you to a professional, a specific professional to work with. And it's made, in my practice, a tremendous difference. It costs you a little bit because people say, how come you're not sending to me? Well, that's okay.
Yeah.
I'm much more interested in outcomes. And I think in the long run, a happy patient has relatives and friends, and that'll take care of itself.
Yeah. Well, that's fantastic. I think most of the doctors that we have had on, I think, share the same sentiments you do. And we obviously, as physical therapists and athletic trainers, definitely appreciate you and doctors like you who feel that way. So speaking of that, before we get into the actual articles, which by the way, I love these articles, both of these articles. They're like definitely timely. We've talked about return to sports before. We haven't talked about the extra-articular procedure, so that's going to be great. But you mentioned that you pick certain therapists that you want people to see. How do you determine how to pick those people, Dr. Dillingham? What is it that you see in a therapist that makes you want to send someone to them?
Um, part of this is shaped by my background, which was, 25 years of professional football, then professional baseball. I ran the Stanford sports program in Santa Clara's for a while, for a fair amount of time, actually. When I see a patient the first time back from PT, let's say 4 weeks, first thing I'm going to do is ask them to activate their quad. My mind is that I'm dealing in medically savvy strength training and reconditioning and recoordination. And I'm going to do the simple things I can do in the office to see if that's happening. And that to me is very telling. If somebody's got a problem and they can't activate their quad and they've been told, well, we'll just work on your glutes, that's not going to cut it. I mean, everything is important. You can't just ignore them. Figure out how to strengthen without the pain. That's your job. And, so I'll even coach the patient in the office, and say, okay, now you can migrate your patella and activate things, go back and say something. So I really look at the result. I'm really looking at results.
Yeah.
And
you can tell. I mean, you can tell someone who's been to a good therapist or someone who's been to an average therapist. You can tell simply by how your patient responds when they return back to see you, right?
Absolutely. And are they doing things that are rational? And so I know I could go on and on forever, but if you aren't strong enough, you can't do a single leg step up.
Yeah.
So, I mean, it's stuff. Yeah, you guys probably go, well, of course. Trust me, it isn't, of course, everywhere. And that's part of why we're having this talk, I think.
Exactly. All right. Do you guys have any other questions, Phil, Barb? Do you have anything for Dr. Dillingham before we jump in?
No, this is great. Thank you.
I just want to say the combo of PM&R and surgery is really cool.
I lucked into it. It was life-changing for me.
That's
Quite
awesome.
by accident. Yeah.
All right. So our first article is rehabilitation and return to sport testing after anterior cruciate ligament reconstruction. Where are we in 2022? There's probably been a little update since 2022, but this is still pretty timely. Ali Gokler, Bart Dinganen, and Tim Hewitt, who Tim Hewitt's been on before, obviously probably one of the premier people in ACL rehab. So, Dr. Dillingham, my first question for you is: you've been doing this. How long have you been practicing?
Come on, guys. Probably 40 years. Let's see, I became 49er team physician in the early 80s.
Early 80s. Okay, so 40 years. How come we still don't know? How come we still don't really know what tests we need to do to return people to sport consistently after ACL reconstruction? There's really no standard. There's a bunch of tests we can use. People have tried a bunch of things, and I don't know that we know, what tests we need exactly yet. Why is that? How come we haven't figured that out? Why is it so difficult?
Well, in profession, Ross and I had a conversation before this, and it's really interesting. So throughout over 30 years of professional sports teams and collegiate teams, I have not had an ACL fail. And it's because I'm doing those ACLs on a different population. They're high-level athletes. And there's a little serendipity in that. I'd like to pretend that I've had plenty fail in other circumstances, so I'm not sitting here telling you that it doesn't happen. But, why don't we have it? How do you standardize the level of the athlete, the level of coordination, the level of motivation? And one of the critical factors, and, I haven't gone through all the literature, and I'm going to let Ross talk to this, is that when I started in practice, most insurance policies, I get 35 or 40 PT visits. Could you imagine that today?
That'd be awesome.
You have to be the CEO of the company to get that. So we could rehab people and we could keep rehabbing people. Now it's 12 visits and go do a home program, which some people can do and some people are no good at. And so you get incompletely rehab people. And then the other thing is, I bet you the studies don't separate out people with sort of the ligamentous laxity, the that are just, a setup to have a failure. The hyperextensible, loosey-goosey in the shoulders.
Yeah, a lot of them they're grouped
Young
together in
soccer
the studies.
player, yeah. So I'm not surprised. I suppose if you got enough people together, the place that this really works is in like a military population,
Mhm.
making control exactly what you do, where you're going to be. That would be helpful. But I'll let Ross speak to the studies because I haven't dug into that, and it really hasn't. Return to play criteria. I'm more dependent on if I've got a good therapist or a good trainer in a team setting, and I usually have a therapist involved there too. You tell me, are they ready? I mean, that's been my,
So Ross, what kind of stuff do you do then? So obviously Dr. Dillingham trusts you explicitly. What do you think about return to sport testing? What kind of testing do you think we should do? And do you have anything to add as to why we can't, why we haven't figured out yet exactly what we need to do? It's really probably more of a rhetorical question than a true question, but
100%. And I think it kind of does go back to a little bit of the changes of the limitations. I think that's a really good point. I think when you are in a collegiate setting where you may not have the same restrictions of insurances or professional organizations, you have a little bit better access to care a little sooner, a little longer, and a little bit more thorough. I think when you get more into the general population, there is so much more things that delay access to care, whether it's referrals or insurance or location or things like that. And I think there's so many different variables that add into our typical population. I don't know how much we are stratifying those in the studies between those people that are really focused from literally post-op day 2 to those guys that come in, which we sometimes see, I'm sure you guys see it in the clinic too, that may come in post-op week 7, right? Or month 4 or 1 year out and they still don't have a quad, right? So I think that's kind of where I think the failure rates that are a little bit higher, I don't know if we're able to stratify the population that we're actually seeing. I would agree that with Dr. Dillingham, sometimes when you get to that really elite level, some of these guys haven't been hurt majorly in their, let's say, football, Pop Warner to high school to college, and then they get hurt in their 8th or 9th year in the NFL. They kind of have it figured out, and they also may have that respect of time because they are valuable to the organization. There's a little bit different risk reward, where when you're in the high school level and say you get hurt your sophomore year and you miss your junior, which is huge for recruiting as well as academically, it's devastating. And to get back from behind that 8 ball, I don't know if they really do. So
sometimes they can't.
Yeah.
Sometimes they can't. Let's be honest. If you make it on a professional football team, you're not the average person. I mean, you're like elite and you're there for a reason. And I agree. Sometimes they do really well because they're just at that level. I mean, they're animals,
I've told people, I've commented that there is a guy who's an elite all-pro athlete is abnormal as somebody in a wheelchair. If you look at the bell curve, they're absolute freaks of nature. You can work as hard as you want. You can't do what they do.
Exactly. And I think going back to the return to play testing and things like that, I think a lot of the basic stuff gets done, I think, in most clinics. I think, the basics of the range of motion, the strength, some of the strength testing, whether it's through handheld dynamometry or even if they do have access to isokinetics. But I think once you do get into those later phases, I think there's not a smooth handoff. And I think some of the best PTs have the best relationships with strength coaches to be able to hand them off to. They have great relationships of the communication of what they can and cannot do, when they should retest them. The doctors are in the same boat, so they aren't looking at just post-op weeks. So just because they're 12 weeks, they can start to run. So I think that there's a little bit of that sequential testing that's ongoing. So, that could be repeated all the way, same, the basic stuff, the range of motion, the girth, the strength, those things are always done. But then when you start looking at a little bit further down, then you start getting into those hop tests. You get into we talked about the limb symmetry in these articles as well. You start looking at those, but what do they really tell you? And I think it's kind of the way I look at it as George is the one who's always kind of talked about that return to play criteria or the algorithm.
Yeah.
I think that's a really good framework. I don't think it's fully complete. obviously, because there are tests that are in there and that aren't, and things like that. But it's a really good framework to be able to follow, and then know the athlete, because there are going to be variances in who they are, like Dr. Dillingham speaking to the hypermobiles, and then some of those that just aren't very compliant, things like that. So they're going to be a little bit all over the board. But definitely, I think being able to utilize the data that you collect from testing, I liken it to a dashboard. It's like being a pilot. If you don't have your altitude and your speedometer, where are you going and how fast and how slow do you need to go? What do you need to change? What do you need to course correct? If you don't have those data points, you don't know where you're at. So the question that we were looking at is, limb symmetry, right? So is that really good when you start to, on your opposite side, getting weaker, right? Is that helpful? Well, yeah, absolutely, it's helpful, but clinical reasoning comes out of that, right? We almost have to think, are they able to generate force? And if they are or are not, is it because of pain, or is it really they're weak, right? So there's helpful information that comes out of that regardless, and then being able to see time changes that occur over 4 to 6 weeks or things like that.
Yeah.
So
What I like about, I agree that I don't know that there's, even the general's algorithm, it's a great algorithm. And I think the beauty of it may not be, like you said, it may not be perfect, but it's something. There was a study maybe it's been 5 to 10 years ago in JOSPT, where they sent out a questionnaire to sports physical therapists, and there was a very small percentage of them that even did testing on people after ACL reconstruction. A lot of them didn't even use testing; they just used time. I mean, they didn't even test. So the beauty of the general's algorithm to me is that at least you're testing something. I mean, you've got some objective parameters versus saying, well, okay, it's 6 months, it's 9 months. Go ahead, Dr. Dillingham. I didn't mean to
I
cut
tell
you
my
off.
patients, they'll ask me, when am I ready to return to play? And I said, well, the graft has to be secure. And after that, you may never be ready to play. You've got to be able to absorb loaded heel strike and when you jump. And that varies on how much PT you have, how hard you work, and how good your therapist is. And I just want to close my ears when I hear it's been 3 months, you should be ready to do this or that. It has nothing to do with it. I mean, it's nice to talk about. And the other thing I'm just going to add in terms of our failures, especially in the high school population, is that beauty contest of junior year, because mom and dad want a scholarship. So does the kid, but they probably want it more because it's going to save them a ton of money. And that's a real battle sometimes, real battle. So anyway.
Can I jump in real quick?
Of course.
One
Of
thing
course,
about
Barb.
the Gokler article that I thought was really interesting is they cited research, and I'm pretty sure it's by Greenberg et al. About 56% of therapists use manual muscle testing as their only method of strength evaluation. I'm sorry, that's sloppy, that's non-objective, and you can't get limb symmetry because my 3 out of 5 or your 4 out of 5, and we're going to think that that's symmetrical limb strength, right? So we are in the process of analyzing a survey that we just did to repeat some information about that, about in the United States, like what do people use for objective strength measurement? And I just got to tell you, like the cliff notes real quick is that it's almost equally as dismal. I mean, it's horrible. So Dr. Dillingham, to your point and to Ross's point, you got to trust the therapist you work with to be able to do the right things, to give you data points that are not just time and are not just manual muscle tests, for heaven's sake. So yeah, I'm kind of jumping on a soapbox, sorry, but I think it's really important.
Actually,
Well, that was one of my questions. Oh, go ahead, Ross.
No, I think that's really a great point to say, because I think there's no excuse for not using some sort of objective measure for force output. Handheld dynamometers, yeah, some of them are expensive, but I'm going to go on record here. For most of my career, since I was out maybe a year, I was using a fish scale from 0 to 25 pounds for upper extremity. So you could get at least a limb symmetry ratio, and for the lower extremity, a luggage scale. So you can be creative. There's ways to do it, and you can get objectivity. You can't use the excuse of, oh, well, I can't afford it. That's a $12 scale. It's
even stuff from Home Depot, for heaven's sake.
Yes.
Yeah. Right. Yeah. That was one of my next questions. Should we? Is there a place still now? We got out of isokinetics for a while. Is there a place for them now? We have an isokinetic machine. We have one at the clinic. We have one at the school now, a newer one. Are isokinetics coming back?
I'll tell you guys, this is that roller coaster, right?
Mm-hmm.
In our profession. And Ross, you've been around long enough, and Barb and Mike and everyone, we've all seen the isokinetic age, right? And what happens in our profession is we have a great tool, and then somebody poo-poos it, and insurance says, well, that's a good excuse not to pay for it. So then therapists go, uh-oh, I'm not going to use it anymore. Remember, we used to have an isokinetic code. You could do isokinetic testing. As soon as that code went away, and then all this functional stuff came in, let's push tires and let's pull ropes and things. That's functional. Let's measure with that. That threw isokinetics out. And I'll tell you now, I'm getting a Biodex in my lab. And I just talked to the guys at Biodex, and it's coming back. Everyone is ordering them now. They are coming back, baby.
Oh, I'm so excited. I miss the
Mine too.
isokinetic days.
Yes.
I love them. I love it.
We have
Dr.
one in our
Dillon,
lab too.
you like Dr.
Well-
Dillon, do you like isokinetic testing?
Well, the isokinetic testing was the standard. It was like you were cutting edge when I started, and then it went away. You're right; they wouldn't pay for it. And is it absolutely necessary? I mean, it's another tool to be helpful.
Yeah.
I got to tell you, I haven't been disappointed in my outcomes since it went away, but that's because people have figured a way around it. And I would not presume to tell you all that it's not useful or may accelerate things. Or really, I think one of the words that I like is precision. Add precision to your analysis of strength. If you can be more precise, if you can tell about maximum strength, about how force is generated, about the endurance of continuing doing that, that's all to the good. It's all to the good.
Awesome. Dr. Dillingham, we have some people that send in question and answers. And I'm probably going to butcher this name, but someone is telling you hello, Janet Laziski.
Oh, yeah, Janet. Hi, Janet.
You know Janet? Okay. Yeah, she's telling you hello. Paul, thanks for being on. Paul Erickson has a question. Should we be looking at the tests as return to sport? Are they not just a minimum clearance bar to move into practice, as still not likely that they are ready to perform with different positional strength, conditioning, and whatsoever? I mean, I think what Paul's asking is, should we just really use these as tests, maybe more than clearance things, because they're simply an objective measure, and we may not know exactly where someone fits with those tests, I think is what he's saying. What do you think, Ross? Phil?
I think that's criteria. Yeah, you're not progressing based on time frames. You're not progressing based on just like testing to the test, right? It's a data point that if they are at what we could consider, say, acceptable, then we can progress them. Because I would 100% agree with what I think he's getting at is there's a difference between returning to your sport and getting back to the performance level.
Yeah.
Right. So you often hear that where people go back and they say, yeah, I can play, but I'm not as crisp or as fast or as quick as I used to be. And then that may come the next year. And then they're like, I'm back. Right. So I think that's the part that might be where the testing maybe more in that as we're progressing through the rehab to get them to where they can participate, to do more sport specific things and then start to practice and then actually start to play, but maybe not to that top level and performance.
Yeah. Ross, Dr. Dillingham, I got this question for you. Within the article by Gulker, they talked about the Webster study that showed that passing a return to sport testing criteria or battery decreased the risk of re-injury on the ipsilateral side by 60%. However, unless I read this wrong, it increased the risk of having a contralateral tear by 325%. So what's going on? What's going on there? Why such a huge increase on the contralateral side when you're decreasing the risk on the side that you actually had it reconstructed on?
Maybe those people didn't pass the test, didn't go back to play. I saw that and I thought, I was asking myself the same question.
Yeah.
I think you're dealing with different populations. I don't know how, how that works. I've certainly not been anecdotally, and that's
What
all
you've
it
seen.
is. Anecdote, it's not my experience.
I don't know that I've seen that either in patients, following
the-
people up. Did you have
One of
something,
the
Phil?
things, yeah, one of the things I want. By the way, Ross, love your dashboard idea. I'm gonna steal that, but I'll give you credit for it. Obviously, one of the things I picked up from this, which may lead back to your kind of observation, Rob, is that people are using different metrics for this outcome, right? So there's return to sport. What sport? The same sport. And then there's the re-injury rate. That's a whole different thing. And when you looked at this article, I love this article. I love Tim's work and all that stuff. I really did enjoy reading this article, but the outcomes are kind of all over the place in terms of what are we defining as return to sport? Is it re-injury? Is it return to the same sport? Is it return to any sport? And that's kind of the problem, is that, and you go back to why haven't we figured this out yet? And the general, George, had a great analogy. It's like, we use these hop tests. Remember, we had that discussion that the 3-leg hop is one of the most popular that's used, and yet what football player does a 3-leg hop?
Yeah.
That was it.
What do you got, Ross? Anything?
I would absolutely agree with that. I think I kind of put that in line as kind of using my little algorithm myself, based off the generals list. But, once you get to that sport specific testing, am I going to do a 5-10-5 with a hockey player on the ground? Maybe, maybe not. Maybe I might do that on the ice, right? There's other skills that they may need to have in front of the net, like battling, right? So they've got to be able to dig into the ice and push the other way and at different rates against a moving target, right? But then the flip side goes for a football player. Do they need to get around on an edge rusher? Do they need to, kind of get down low and spin, get sideways and things like that? So I think those are the things that come later that we really need to be able to start focusing on, that may not be able to be tested out with the hop tests. Those just don't do that. So I think you do have to still build in some other things that are going to be very specific to what they're going to actually do.
Did you see that question that came up? Ross, is that why you answered that? No, you didn't. Okay.
Oh, no, sorry.
So here, the question to you, I think, Ross, from Colin Timpolis.
Okay.
Colin is from Sacramento. The question says, question for Ross: do you perform different return to sport tests for hockey players compared to other sports that involve more planting? That's why I
Yes.
thought maybe you brought in the hockey because you saw the question, but I think you just happened to be bringing in hockey at the same time.
Yeah, definitely. No, there's definitely different things you do, and those might be more skating drills. They might be more like just using the entire rink, right? So you do drills that are we start them out as literally recreational skating. They might look really stupid, they're in a tracksuit. But then once you start doing that, you add in different equipment, you start kind of using the entire sheet of ice, then you start cutting it down, you make it smaller, then you start bringing other guys on, you start, just everything. It's a gradual implementation. The beauty of that is, especially once you get to the higher levels, you have coaches that can start to help with those drills, right? So I may not even need to think about it. I might just say, hey, let's just keep them a little bit back from full contact. Let's say this. And then the other guys are like, okay, got it. And they're designing drills that are really pretty safe. And they'll check in with the player, look over at me and go, okay, cool. But yeah, definitely being more of a background in football, whether it was high school and collegiate and things like that, and then going to hockey later, very different in the late stages, extremely different. Yeah.
Hey,
So
Ross,
it sounds like, it almost sounds to me like maybe we need different return to sport tests, probably for different sports. And we've talked about that on here before. We've posed that question, maybe there's a set of tests that we do for a basketball player that's different for hockey and different for baseball and or track and field or something like that. Maybe we don't use the same tests on everyone, and we can stratify them based on sport. And then someone before, I put it on the question for day 2, maybe we even do different tests. You might be able to, I mean, if you really wanted to go down a rabbit hole, maybe you do different tests for different graft types. certainly different time frames, I think. Dr. Dillingham, what do you think? When do you want your people, what primary ACL technique do you use? And what is a time frame when you think it's safe to start doing return to sport testing in general?
Yeah, well, first, early on, long time ago, I did hamstring, which I no longer do because it just isn't as good as a patellar tendon. I haven't migrated the quad tendon because I don't see any clear advantage to it. I mean, I really don't get it other than you get to buy a special instrument from a company and make them rich. And I use a lot of allograft, Achilles tendon not irradiated, because the data is pretty solid on that in big populations, it's as successful as the bone patellar tendon bone, although anecdotally and emotionally, I find that hard to believe, but the data says it. So I really am bone patellar tendon bone auto or Achilles allograft with a lot of lateral tenodesis thrown in. And I haven't seen much difference. I've had people return to professional football as early as 4.5 or 5 months. And I don't differentiate based on graft type, really. I think it's, get your flexibility and get strong and be ready to go. I think one of the things that helps, and I was going to comment on this with Ross, the higher you go in sport, the easier you have it, not just because of the athlete, but because of the coach. Particularly in professional sport, that athlete is their means of production. If you're a high school coach and you've got your best player and he's one of 2 or 3 decent guys you have on your team, he's going to graduate. He doesn't have a lawyer. Professional athletes do. In college, most of them don't have lawyers, although now with what's going on in the NCAA, maybe they do.
Yeah, they probably do.
But you've got, Ross commented about the coach. I can depend on them. It's true. The worst situation is the lower you go on the level of sport, the more risk you have, I think, based on coaching and playing people when they aren't ready, which is an aside to this, but it's an editorial.
No, we like those too. We got a question, but it's really not a question, I don't think. Dr. Dillingham, do you know Todd Lazenby?
Oh, yeah, absolutely.
Todd Lazenby. Okay, he said, Dr. Dillingham.
Hello, hey, Todd, how are you?
Dr. Dillingham said, it's great to see you. In relation to your experience in team settings, having a good strength and conditioning coach involved is key to making a great return to sport decisions. I know having a strength and conditioning coach involved in return to play conversations was key for your success in the professional setting. Having a good strength and conditioning professional involved in the sports physical rehab work, on field work, is so important to being assured the athlete is ready to return to play as safe as possible. Strength and conditioning coaches may be a luxury, but they're really key in helping return to play decisions be as accurate as possible. And I think that's what you were alluding to, Ross.
Yeah, we had a guy, Jerry Attaway, who was as much a physiologist as he was a strength coach. And that combination, he was unbelievable. He was so far ahead of his time, when Walsh was coaching there, and he was fantastic. And Todd and I worked together for years, so it was great. It's great to hear from him.
Awesome.
Yeah,
awesome.
I'd like to comment on that real quick too. I think kind of going back and piggybacking on what Dr. Dillingham said about the youth athlete to the high school. I think, having experience of coaching and also being an athletic trainer at the Pop Warner to high school levels, when you're an AT at a high school or Pop Warner, you're doing a lot. I mean, you're kind of the EMT, you're the AT, you can be the strength coach, you're also a position coach. You're doing everything, right? So, and then that kind of translates into the general orthopedic population. So if you've got a high school or a youth athlete, you do have to be across that spectrum. You got to understand the athletic training, the strength conditioning, the return to play. But when you're at the professional level, you've got guys that are way smarter than you on the strength side, and guys that are athletic trainers way smarter than you. And then you got the team physicians of multiple specialties, and you've got resources, right? And you've got the agents, and you've got the players that are elite. So
use your team.
Yeah, you're a team member. You have a role that's maybe that big, and you stay in your lane, but you communicate with a team that's across the room, right? And I think you just don't have that luxury at the younger levels, and that is the hard part. But I think the more you can learn that, and then you can adjust to, if you do get that luxury to work at the elite level, it's a game changer. It really is.
Well, Ross, you got time for one more question before we move on to the next next paper. This is from Jess Indo. You know her, don't you, Ross? Does she work with you still?
Yeah, no, she did. She was one of
Yeah.
our residents.
I thought maybe she's like sitting just like 10 feet to the left of you and she's sending in a question.
No, sorry.
No. All right. So
Hi,
Jess, thanks for joining. Hi, Ross. One thing that was mentioned in detail in this article is the use of allometric scaling instead of using limb symmetry index for strength testing. What's the latest research on this and the usage of it in practice?
Well, I think that is definitely something we're talking about. We're starting to shift towards a little bit more towards factoring in their size, their things like that. But also the other thing too that I've started to look into and also start to utilize, which is a little more time dependent, but torque to body ratios, things like that. It does take a little bit more work, but it is helpful because it's more specific to that particular person. We've definitely kind of pushed that a little bit more, especially with our latest resident to look into it and figure out how we can learn a little bit better with that.
Looking at other parameters. Yeah.
Yeah, definitely. Yep. But I think that was kind of the step on top of the limb symmetry.
All right. You guys got anything else? Phil, Barb?
I just wanted to real quick. I know we got to jump, but I think your comment on strength and conditioning coaches is really important. It was actually, I think, mentioned in the article that was a big factor in success. And that nowadays the strength and conditioning coach is a huge important part of the team. We used to not, communicate as the ATs in the training room with the strength coaches, but now they've been taking over a lot of that post rehab. And I think that the key to success in return to play is that physical therapist that thinks like a strength and conditioning coach, or the strength and conditioning coach that thinks like a physical therapist. And that is the best blend that we can get to today. And that's the key to success.
Love it. Love it. All right. So you guys ready to go to the next article? Is that a yes?
Yep.
Yeah. All right. So the next article is from Italy. It is Alberto Grassi, I think is how you say the last name, and colleagues. A lateral extraarticular procedure reduces the failure rate of revision anterior cruciate ligament reconstruction surgery without increasing complications. So, Dr. Dillingham, I think this is probably a great time for you to jump in, if you don't mind, and because my guess is there's a lot of therapists that maybe see a little bit of ACL, don't see a lot of ACL. They might not even fully understand what the LET is for. Do you mind giving us kind of a little historical perspective and let everybody know exactly what that procedure is?
Right. I'd be glad to. And I'd also comment that Rizzoli's a great place. I know a lot of the rehab guys there, and I've visited there in the past, and this is a good group. Let's go back long time ago when I started in orthopedics. What we did, because I literally was in orthopedics in my residency when people were arguing whether an ACL graft really could work at all. And there was a guy who's Jones in Little Rock, Arkansas, and I visited this guy, and he had, in his office, and he started using bone, patellar tendon, bone, and got people interested in it. But then it would fail at times, and the technology wasn't as good, and the treatments weren't as good. So the operation I used when I started in practice was a bone, patellar tendon, bone backed up with a 25-centimeter iliotibial band graft, which is tubularized, put through the lateral femoral condyle back to Gertie's tubercle. It creates an external rotation contracture that stops the pivot shift cold. And if you don't pivot, your knee is going to be stable. Those operations worked very well. And actually, there's an interesting paper Laprade published, 4 or 5 years ago. And if anybody wants pictures of these procedures, there's nice art in this thing showing that particular procedure and the multiple others that have come its way, and they all do the same thing. I don't care what you call it, you're creating a lateral external rotation contracture so you can't pivot. Those people didn't fail. The knees were rock solid, and I see some of them now 3 and 4 decades later. They've stayed stable. They did not fail. But what were the difficulties? One, long rehab. Back in those days, we put people in a cast, took the cast off after 3 or 4 weeks, and then they did a year of rehab. So then what happened? This is marketing. I'll never forget this. And Ross and I talked about it. I had a patient come in and say, I said, this is what we'll do. She said, I'm not doing that. I saw Dr. So-and-so. He said, I don't have to do that. All I need is a graft in the middle of my knee. And it didn't take long, and you couldn't sell that thing at all. It was an Edsel. And there was a marketing push to get away from it. And it was because it was a difficult rehab. And so then we went to single grafts, hamstring, allograft, this, that, and the other thing. And we all know what the failure rates were. So I'd say about 10 years ago, I had a fellow who saw some of these patients, and he said to me, you know what, some of these people, you ought to do what you used to do on people because they didn't fail, and now you've got somebody you're doing a revision. So it was like, duh, wake up. And then the stuff came out about the, the lateral capsular ligament, which I don't think is as important practically as creating an external rotation contracture. I don't care how you do it. As long as you don't let somebody internally rotate their tibia, they aren't going to pivot and they're going to be stable. So you just have to have an operation you like. And so I started doing the ALL reconstruction with the lateral tenodesis, and then I dropped the ALL part, and it works just as well. And now I use an allograft semi-T from Gertie's underneath the fibular collateral back to Gertie's, fix it in extension, external rotation, and it has worked really, really well, and it's simple. It also avoids some of these concerns about lateral joint pain and so forth that I read about lasting months. It just doesn't happen in that population.
Yeah.
So that's sort of where it's gone. And this paper really points out it's all revisions, but which is even more potent group, that if you add the LET, your failure rate goes down, your complication rate doesn't go up. And I think you can just grind through the literature, and that's the fact of the matter. So
sorry, I got two things I need coming on. First of all, now you're gonna have to go back and explain what the Edsel is. I don't think anybody probably on, except maybe those of our age, know what the hell the Edsel is.
Okay, a really bad car that nobody wanted.
A really old bad car.
Yeah,
a really
kind
old
of,
bad car.
right up there with the DeLorean, right?
Yeah, really.
Way older than DeLorean.
Yeah,
though.
way older than
really
the DeLorean. I know. I was
out
giving
there,
that for some middle-aged people that maybe, around the 80s that maybe knew what the DeLorean was. Now, and second, so Dr. Dillingham, what you're saying is you used to use it for a primary repair. You got away from it for a while, but now you're doing it for primary too. Also,
I do it if somebody has a significant pivot primary. I do it in every single revision. I do it. I don't do it in every single primary. Although there's part of me now that as I'm sitting around thinking, maybe I do that because the complication rate's so low. There's a little hardware out. Once in a while, you have to take the screw out, but that's been it. I mean, it has really been a game changer. I've literally had people hyperextend their knee. They're running stadium stairs, hyperextend and tear their intra-articular graft, and they did not have a pivot. The lateral tenodesis was still working.
Was holding it.
They didn't have a pivot maneuver. They had a traumatic hyperextension. So it does work. It does.
I've only seen it in revisions. I haven't seen anyone do it as a primary, but what you're saying makes complete sense to me. If they have a big pivot shift, it seems like it would be reasonable. It's
telling you that the lateral structures have really stretched out, and it's a good assessment. It's a exam under anesthesia. So I tell my patients, it's game day. We examine you under anesthesia always before we do an ACL to be sure of what your pivot is. And if you've got an excessive pivot, we're doing a lateral procedure.
Yeah. Just add it on. And you always do it with you said semi-tendinosis?
I use a semi-tendinosis, the world's simplest lateral procedure. Underneath the fibular collateral, back around, externally rotate the tibia and tack it down.
Are there other sources that people use nowadays?
Are there other procedures? Yes.
Or other graft sources?
The most common one used is the native iliotibial band. Part is harvested and tacked, run under the fibular collateral and tacked, and where you tack it creates a change in the name. Whose procedure is it? Modified Ellison. You can go through a long list. It's all the same thing. It's an iliotibial band brought underneath the fibular collateral, tacked somewhere to hold the knee from internally rotating or keeping you from pivoting.
Yeah, good. Phil, What did you think? This was a systematic review, meta-analysis. I mentioned in the list of questions to you guys that this wasn't. They mentioned that none of these studies that they looked at in this article were randomized controlled trials. They were all done retrospectively. How does that affect your looking at this study and looking at the results of it?
Yeah, sure. Obviously the level one or the the randomized controlled trials will be the best way of looking at it, but it's hard to do that when we look at particularly orthopedic surgery outcome studies. A lot of these are going to be more observational. What the authors did do a good job of is they did follow a lot of the great recommendations for systematic reviews. They used like Cochrane's RevMan. They did the Prisma outline. They used the Nottawa scale for observational studies. So I think that the results are, even though it's not randomized controlled trial, it still gives you a little bit more. And we've talked about how randomized controlled trials just sometimes aren't practical. And these observational type studies tend to provide us a little bit more of that practical aspect of it. And kind of what I wanted to do, if we have a few minutes, is just to look at kind of the results of it, if that's okay with you guys. If I can share
Yeah,
my
that's fine with me. Is it okay, Ross? Dr. Dillingham, you okay if
Yeah.
Bill shares the screen?
Yeah, and I'm not going to spend a lot of time because you guys know I geek out on stats, but a lot of times clinicians will look at these papers and just read the results, and all what they look for is, was it significant difference or not? And I continue to preach that the p-value is not beneficial for clinicians. It's great for statisticians, but it doesn't mean a lot for us as clinicians. And this was a great example, and I really appreciate you guys picking this article, because these are what we call forest plots, real quick. So when you look at a meta-analysis, and what the authors were doing is they were looking at different outcomes. So they were looking at the lysoome, the IKDC, the Tengers, and what they were looking for were studies that was part of the inclusion, studies that included these outcomes. And you can see those listed here. And actually, all of the studies that were included actually included these outcomes. Sometimes you see outcomes that weren't included in some of the studies. So this one was one where all of the studies were included. They're listed here. And you'll see that, and when you do a meta-analysis, you have to have two comparisons, right? You have to have a comparison, in this case, with and without, the combined or the isolated. So you're going to see this, and within this study, this was the mean, this was the standard deviation, this was the total number of subjects. Each of these studies then compares those two and gives you this mean difference. What was the difference between those two groups, which is what you would see in any study. And then they graph it here. And this is the visual that really, I'm going to give you that kind of cheat sheet real quick as a clinician to look at. So when you look at these lines here with the little dot in the middle, those are called confidence intervals of where we think the true value is based on the results of the study. The wider it is, the less precise we think we are, the less confident we are in the result. The more narrow we are, the more confident we are, and that's usually associated with a larger subject size. So this study, for example, the third one, you see how small the confidence interval is? That's a very large study. You can see it's kind of, what was it here? 88 subjects, right? So that makes sense. And so, and it has, but it was also to the right of the zero. So anything to the right is a positive, to the left is a negative. And I'm not saying that that's a good or bad result, because sometimes that can change. But when you see that this confidence interval does not cross zero, this is the key. It is significantly different. Okay. If the confidence interval crosses the zero, it is not significantly different. The p-value will be greater than 0.05. We see that here, 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 here. But here and here, these first and third studies are not touching the zero. They are significantly different. I already said, though, that this p-value issue is not really clinically relevant. But here's where the money meets the road, right here. It's this diamond at the bottom. This is the total effect, the total difference between all the studies. What I want to point out here is that, does this cross zero? Does everyone agree that this crosses zero?
Mm-hmm.
Yeah, it does. Right? So let's look at the confidence interval. The confidence interval is the range of values that we think includes the true value in the population. Negative 0.97 and 7.89. How close is this one? Negative 0.97 to 0. It's pretty darn close, but it still crosses it. So guess what you read in the paper? The p-value is greater than 0.05. And so you discount this entire study sometimes because p was greater than 0.05. But look at the chance that the true value is actually on that right side. Okay. That's what I want clinicians to look at, to make sure that you understand the p-value doesn't really tell us a lot on how to make a clinical decision. It's what's the confidence interval and where is that 0 located that makes it non-significant. You can see it's barely touching. Here, down at the bottom, I got a little bit more confidence that there's a possibility there is no difference between the groups. So it's a real quick and easy way for clinicians to actually not just read the conclusion and look at the p-value and what the researchers say is it's not significant. Look at the confidence interval. Look at these values. If the value, again, that is clinically significant is within the confidence interval, that doesn't rule that out as a good outcome. So there, I'll be quiet and stop nerding out.
Awesome, Phil. Thanks for the stats 101. You know, you used to do those all the time. You don't do it as often anymore. You need to do that more often.
I know.
That's
but
good
this
stuff.
gets me fired up. We haven't done a lot of meta-analyses.
Yeah,
And,
that's
and
great
Phil,
stuff.
the next time you do it, I want you to talk about the size of the boxes. Those little green boxes, that means something too. My stats people are all about that too. Like the size of the boxes have to do with the size of the study as well as the differences. And so it's
Don't
the
talk
weight of
about
the
it.
study.
Don't talk about it today, though. We want people to
Sorry.
have a reason to come back.
Yeah, it's
Okay,
the weight.
sorry.
It's
It's a
the weight of
teaser.
the study is how much weight it adds to the
Yeah.
It's a
over.
weighting thing.
Ross,
It's a weighting system.
Ross, we call that a teaser.
I
By
like
getting
it.
people, yeah, we're getting
like
people
it.
excited about stats.
Competition.
One more question. Believe it or not, this it seems like every week I feel like we just get started and then it's time it's over. But we got a question from Brady Soley, our man Brady Soley, who was on with us a couple of weeks ago with Dr. Larson. Great, that was a great one. Dr. Dillingham, are there any downsides of the LET or ALL reconstruction in your opinion? Any risks in capturing the lateral side of the knee with an extra-articular procedure, or maybe even OA down the line?
You know, people talked about if you stop the normal rotational activity of the knee, are you going to get osteoarthritis? So there are two things I'd like to comment on. One, no one's shown that to be the case, and it's been looked at. Number two, nothing's going to give you lateral arthritis quicker than a big pivot where you hammer your knee, tear your lateral meniscus, and impact the articular surface. So even if it did cause a little theoretical increase in wear and tear laterally, it's trivia compared to the effect of a real high energy episode of pivoting, which is disastrous.
Great answer. I don't know. We got like 3 minutes. You guys got anything? I just want to tell Ross how much I miss the guy, man. I don't see Ross enough.
I said the same thing, Ross.
I know.
Yeah.
We were just saying that. My bad. I know I have not been
No, it's not. I'm not saying it's your fault. I'm just saying, circumstances and things like that. But man, I love Ross, man. He saved me. The first time I met Ross, I was in where was I at, Ross?
San Ramon.
San Ramon. My
Yep.
computer. I went to go do a 2-day knee course, and Ross and a friend of his are at it, and my computer doesn't work at all. And Ross saved the day, let me use his new computer to do my 2-day talk. I love the guy ever since, man.
Love you, Ross, buddy.
Love you too. It's been a long time. So that's the thing is I need to be a little bit better than just showing up at CSM. So.
No, you're good. Dr. Dillingham, thank you so much for joining us. I hope we can
You're welcome.
have you again, man. You're so cool. I like talking to you. I like listening to your stories. You're a wealth of information. I hope we can have you again. I hope you'll join us again sometime in the future if we ask.
Thanks, Doc.
Yeah,
Yeah.
thank you very much.
All right.
Thank you,
Thanks,
guys.
everyone. Reminder.